On behalf of the Centers for Medicare and Medicaid Services, the Administration for Community Living, and the Indian Health Service, I would like to welcome everyone to the Long-Term Services and Supports webinar series. My name is Julie Cahoon, and I work for Kaufman & Associates. I will be the moderator for today's webinar. Today's webinar is Aging, the Opioid Epidemic, and Treatment Considerations for American Indian and Alaska Native Communities. Before we begin, I would like to highlight the main features of your webinar interface. First is the main window, where you see the PowerPoint slides to the left side of your screen. At the bottom right of the window is the Q&A pod. You can enter a question for our presenters at any time in the Q&A pod. The Q&A session will take place after the presentation. If you need technical assistance during the webinar, please enter your tech support question in the Q&A pod. Our tech support staff will be monitoring these questions throughout the webinar and will work to answer your tech support questions right away. You will receive an answer in the Q&A pod. Finally, please be aware that today's webinar is being recorded and that the recording will be made available online in the near future on cms.gov. Please note this webinar series is supported by a contract awarded by the Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenters and do not necessarily represent the official position or policies of the Department of Health and Human Services or the Centers for Medicare and Medicaid Services. Our presenters today join us from the National Opioid Response Network. I will now turn it over to our presenters to offer an introduction. Ben?
Thanks, Julie. Hi, everyone. My name is Benjamin Nguyen. You can call me Ben, and thank you for having me today. I'm with the National Opioid Response Network, funded through SAMHSA. I'm one of the technology transfer specialists, which I'll kind of give an overview as we go through. And I specifically cover the Southwest, so that's New Mexico, Arizona, and Nevada. And I'm based at UCLA Integrated Substance Abuse Programs and SAMHSA Pacific Southwest Addiction Technology Transfer Center. Just a little bit of background, I'll explain more later. I received my MSW at UCLA Luskin School of Public Affairs in social welfare and concentrations in geriatric social work, as well as human services management. And then I'm certified with public health for the National Board of Public Health Examiners and registered as an associate registered clinical social worker with the California Board of Behavioral Sciences. Thank you all. I look forward to sharing what we have today.
Hello, everybody. This is Holly Echohawk. I'm originally from Oklahoma, and I'm a tribal member of the Pawnee Nation of Oklahoma. My training is in organizational behavior within a school of psychology, and I'm a former behavioral health director for both mainstream state licensed mental health organizations and tribal behavioral health as well. And I'm currently I work as a core consultant for the National Opioid Response Network, and I'm really happy to be part of this today.
Hi, everyone. My name's Joan Candell, and I'm a family physician, and I have been involved with the Opioid Response Network as a treatment consultant for two different groups. One of them is in the state of New Mexico, and the other is for the American Indian Alaska Native Work Group. And my background is that I've worked for over 23 years in the Indian Health Service. 18 of those years were on the Navajo Nation in Arizona, and a little over 5 years on the Hickory Apache Nation in New Mexico. And I have about 15 years of experience working in the treatment of opioid use disorder. And I'm really happy to be here today. Thanks.
Wonderful. Thank you all for joining us today and being willing to share your experience and expertise on this topic. I will now turn it over to Ben to give an introduction to everyone about today's topic and a little bit of how the presentation will unfold for you.
Great. Thank you.
2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2. 2.
looks like I don't see the screen yet. Can everybody see that?
Yes, the screen is visible.
Okay, I think, Julie, if you'll help me advance slides, that'll be great. So just the title slide. Today's presentation title is Aging, the Opioid Epidemic, and Treatment Considerations for American Indian Alaska Native Community. These are our three presenters. And next slide, please. So just kind of a disclaimer at the beginning with who we are, what the Opioid Response Network is. So the Opioid Response Network was created with SAMHSA's State Targeted Response Technical Assistance Grant, and it is designed to support STR grantees as well as other individuals and organizations by providing resources and technical assistance to help address the opioid epidemic as it appears in every local community. And so technical assistance is available to support evidence-based prevention, treatment, recovery, and prevention of opioid use disorder. Next slide, please. And so basically our approach is to build on a lot of existing efforts and partner with different infrastructure and existing programs and services such as this existing Medicare and Medicaid webinar. And so we really want to enhance and refine and fill in the gaps rather than creating the wheel. Next slide, please. So our overall mission really is, as mentioned before, to provide training and technical assistance through local experts to enhance prevention, treatment, especially medication-assisted treatment like buprenorphine, naltrexone, and methadone, and recovery efforts across the country to address state and local specific needs. And so here, that's why we've brought in different consultants, Holly Echo-Hawk and Dr. Joan Candell, from different areas across the nation to be able to provide that information. Next slide, please. So the Opioid Response Network basically provides kind of local experienced consultants in prevention, treatment, and recovery to address the epidemic. We accept different requests for education and training, and all of it is free and funded through SAMHSA. It is a national network, so it's organized by each of the different health and human service regions. So each state and territory has a designated team led by a technology transfer specialist. Washington in the Pacific Northwest technology transfer specialist. Her name is actually Jan Schnellman, and she's on today, and she's really what has brought us together here, reaching out to the national network to be able to provide you different perspectives because this is a webinar, so we're not as geographically bound. But the technology transfer specialist is somebody who basically operationalizes a lot of the work, taking a lot of the different ideas, evidence-based research, and experience from the different consultants to merge them with the needs of the community and translate them into actionable and items that can be delivered, whether that's training, education, or hands-on technical assistance support to help see a program or policy come to fruition. Next slide, please. So you can submit a request online at www.opioidresponsenetwork.org, or you can email orn@AAAP.org, and AAAP is the American Academy of Addiction Psychiatry. That is the host and kind of the lead PI on the grant. And you can also call the general number at 401-270-5900. Next slide, please. And this is just a general funding initiative announcement, basically that we are funded by SAMHSA and that the views expressed here and any type of trademark or trade names mentioned are not necessarily representative of the U.S. government or don't to represent any kind of formal endorsement. So that's basically that. Next slide, please. All right, so this is an overview of today's presentation. We will first begin with the field of aging, kind of my professional background, because I think it's important for the audience and people to know where a speaker is coming from, so you can see my own biases and know them up front, and then also we can see why we have different perspectives weaved in. So that's the first part, really, about aging and my background. And then the second piece will be intersections of aging with the opioid epidemic, so different trends we've seen there. And then the next part will be a discussion with Dr. Joan Candell and Holly Echo-Hawk to discuss treatment considerations for American Indian and Alaskan Native communities. So really taking what aging perspectives that I'll be able to present to be able to integrate and apply to the opioid epidemic and tribal communities. And then we'll end with about 10 minutes for open Q&A, and so thank you for kind of holding your questions until the end. Next slide, please. So yes, the first part is the field of aging, my background work, and demographic trends. So that's kind of where I fit in with this and how we've seen aging in society. Next slide, please. So I want to begin really with terminology. And so within the field of aging, you have gerontology and geriatrics. And these definitions, the first two at least, are from the Association for Gerontology and Higher Education, which is a great association that really helps standardize the field of gerontology and understanding it with geriatrics. So geriatrics we can really understand as the study of health and disease in later life and the comprehensive health care of older persons and caregivers. So really that medical side, the healthcare side of it, we're dealing with older people and the changes that happen there. And that gerontology is the study of the physical, mental, and social changes in older people as they age, as well as the investigation of the changes in society resulting from an aging population. So really where we see this is application to programs and policies. It's a little bit more broad than just healthcare because aging really affects multiple disciplines and domains in our life. And then aging, as just kind of a general, is changes that take place in the organism across the lifespan, good, bad, and neutral. And so we do emphasize that it is changes, not just decline, as many people are kind of socialized into viewing aging as. Next slide, please. And so here's kind of my professional identity, background, and work. And so I always like to say that gerontologists, one of the things that we always tout as gerontologists is, up until now, the last 50 years, we've had a lot of public health advancements that have extended years to life. But now we are tasked with how do we improve the quality of life? So it's not just years to life, but how do we add life to years? Because that's really important and something that has been missing for a lot of this new millennium. And so my background with geriatric social work and social gerontology is kind of on the screen. And Julie, if you could make sure to show all of the different bullets, I think they transition slowly. So as long as those are all played out. Kind of my background as a geriatric social worker, I've done work implementing a program called Time Out at UCLA, and that is a respite care program that was adapted from Temple University, connecting university students with older adults in the community. Usually at UCLA, it was older adults that were neurocognitively impaired, and so that really allowed to build intergenerational bonding and then provide respite for the caregiver, who was usually a spouse. And then I also did work with the California Geriatric Education Center, which was funded through HRSA, and on that was a variety of different education projects for dementia training, as well as just a variety of different education for providers and interprofessional training. Then I also worked at UCLA Health in a multidisciplinary comprehensive care center, coordinating a lot of care across the lifespan. And then most recently, or not most recently, 2 years ago actually, I was with the VA working with their GeroFit program, where it was a health promotion, disease prevention, exercise program to really engage older veterans to maintain physical functioning and also create a sense of community to thrive in late life. And then from social gerontology, again, the piece that relates more to programs and policies, I helped start up a nonprofit called Music Men's Minds, which really created intergenerational bands of students and older adults with dementia and neurocognitive decline to be able to use music as a way of therapy and community building to build bridges there. And then when I was at the city of Santa Monica, worked with trying to deliver an age-friendly initiative there and sign on Santa Monica to become an age-friendly city. And so that's a big movement across the nation through AARP and the World Health Organization to revamp a lot of city services. And currently, I work with the Westside Pacific Villages, which is part of Village Movement California, as well as Village to Village Network. Villages are it's a national movement of local grassroots nonprofit organizations connecting older adults with other people in the community to provide services and different supports to help people age in place, because it gets very difficult to continue to live in your community as you grow older, and there's vulnerabilities that are had, and nobody really wants institutionalization, and that's kind of it's not homey and it's very expensive, and so we work to prevent that and really promote active aging in your community. And then some other things I've done with the Gerontological Society of America was this reframe aging age stage evaluation. It was a presentation we did at the International Association for Gerontology and Geriatrics in 2017, the summer of 2017, and that used a lot of arts and creativity to showcase the talent and a lot of the potential that is earned in late life to reframe what it means to grow older, because in light of a lot of the negative biological kind of stereotypes of what it means to grow old, I think the arts and aging and humanities can really redefine and give a sense of purpose. So that is my background, and I mainly want to introduce with this because a lot of my background is related to working with older people and organizations related to community health and aging, but not necessarily just substance use. And so while I'm on this project here and this grant through SAMHSA, we're addressing opioid use disorder more broadly. It hasn't necessarily intersected specifically with older adults, and that's why we brought on Dr. Joan Kandel, who has worked in the treatment sphere, and then Holly Echohawk, because I haven't had specific experience working directly with tribal persons besides my work with New Mexico and a lot of the communities there. But I think this is just so you know where I fit into a lot of these pieces. So next slide, please. And we'll move forward with the aging and demographic trends for population aging. So what this is looking like as a society. And so on the image to the left, you'll see there is a pyramid for the 1960s and then a projection for the 2060. This is really what population aging looks like when we're talking about it. And it's characterized by longevity, which is increased lifespan and life expectancy, as well as prolonged mortality. So you're seeing people, we are living longer, and so death is being delayed. Then we also notice low fertility rates. So what this looks like on the image is you'll see in the 1960s, most people, a lot of them already had died off as we approach to the upper 80s. And a large proportion of the population is younger, and that's kind of what we have had for a while. And what we're seeing now is the shift of people living longer. So the top part of the pyramid is widening because there's going to be more proportions of individuals living longer. And then the bottom portion is actually not growing as much because of these low fertility rates, which there are a variety of different reasons. You see women entering the workforce, or women not necessarily being tied to the role of needing to be a mother, to be somebody in society. And so that's decreasing the amount of children that you have. And so that makes the bottom part a little bit less. And so instead of seeing a triangle, you're really seeing the shift to a trapezoid. And that's what we're seeing for population aging. And then with longer life comes higher morbidity, because as you age and live longer, and instead of dying, you'll have increased exposure to getting a disease and things like that. So next slide, please. And so this is happening globally. We're seeing this happen all across the world. It's not just the U.S. And you can see within the next really 30 years, we'll see at least a doubling, if not tripling, of older adults across the world. And the fastest growing segment is actually the oldest old. So the individuals over 85, that is actually growing about 3 times, whereas in general, over 65 is doubling. Next slide, please. And so when we're looking at different states, we're also seeing different patterns here. Across the nation, the median age continues to rise. That's the image on the left. And then when we're looking at different data and statistics, the oldest states with the highest proportion of older people over 65 is Florida, Maine, and Puerto Rico. And then you have West Virginia and Vermont after, as well as these other states after with 18%. In terms of raw numbers, California has the most, followed by Florida, Texas, and then New York. And while I was going through this presentation, trying to adapt it and understand what it looks like in Indian country or tribal Native Americans, I really didn't find much data, so there was scant research about it. And what I did find was mainly through the National Congress of American Indians, and that actually noted that a lot of the demographics in Indian country are younger. So they didn't really attribute much to that, and I know we can certainly have a discussion a little bit later with Dr. Kendall and Holly, but I know one of the things that we can also maybe attribute this to is the earlier mortality, and so lower life expectancy among Native Americans and Alaska Natives. So that's something that can be attributable to the lower, younger demographic, but certainly that does not mean that it's not as important. Next slide, please. And so what does this all mean? You know, it's great to know that it's happening in our society and looking at the demographic trends, but what does this mean? And so these are kind of the different impacts that you can expect with an aging population and just a society where people live longer. It certainly impacts culture and society. You know, a lot of what we have as a society is very youth-focused. There's all of this anti-aging. There's a lot of negative stereotypes about aging. Ageism is very real. It's one of the few things left in the workplace that people can overtly talk about. You know, we praise not having wrinkles. We praise looking a certain way and looking younger than your age. And we joke about like, oh, I'm getting older. And so we really don't question a lot of this like negative stereotypes about aging, which do impact how we view ourselves and ultimately our health outcomes. One of a psychologist at Yale, Rebecca Levy, did great research on this about how our negative stereotypes in aging we end up internalizing in late life. And the more negative those are, they affect how well we function in late life and as well as our life expectancy. So there's a lot of work now being done to disrupt those negative stereotypes about aging and how we need to change the narrative of how we talk about growing older, because it isn't something to be ashamed of. It isn't something to be viewed as negative. It is a gift. The alternative is death, you know. So that's really what we're looking at on a cultural and society perspective, at least one of the things. Can't speak to all of them in this time frame. The next piece is really community health. So a lot up until now, a lot of city services, programs, and county services have been designed in mind for up until maybe 50 to 60, and then afterwards you retire. And I think a lot of the time societies like you have been forgotten. You have kind of been marginalized outside of the workforce and the community, and so you notice this, for instance, in like libraries. This is a big example I give a lot. Libraries are really supposed to be lifelong learning hubs, but you see it designed for children and story time. And if your median age across the nation is approaching 40 and you're only having public city services as really just designed to gear towards the children, then how are we really allowing people to continue to thrive throughout your life? And so what this looks like with city government levels is we're looking at a lot of city government municipalities approaching AARP and World Health Organization to adopt this age-friendly framework and network to really think about how to design services that are more sustainable and receptive to individuals across the lifespan. So when we're still looking at programs that support older adults, it's really programs that support every age, but just looking across the lifespan. So that's kind of what we mean by community health and looking at more of the social determinants of health. And then the last piece, there are many impacts with the health and welfare system. So I pull here an age-friendly health system framework from the Institute for Healthcare Improvement. And we're really looking at what this means as we're going to be serving and working with a lot more older people and people living longer. This is the 4Ms framework. You know, we want to look at what matters: medication, mentation, and mobility. These are not necessarily things that you would use working with children, not that you wouldn't, but these are things that are particularly important when you're working with older people. You have a lot of the mentation that's screening for whether it's depression, delirium, or dementia, medication and the issues with polypharmacy and managing all of the different comorbidities, mobility with increased fall risk, and then what matters is in terms of looking at how you can continue to do your activities of daily living and find a sense of joy, purpose, and meaning in your life. These things that we almost always take for granted. So that's really what we're looking at there. And then I will add also long-term support services. Those are very expensive, and that's going to change a lot. You know, in Sweden, they have it integrated into their city government and different infrastructure because a lot of the long-term support services are at home We don't have that. Everything in America is privatized, mainly at least, if you want the long-term care that is going to be sustainable. And so how are we going to address this in developing future programs and policies? That's kind of what we have to look at. Next slide, please. All right, and so the next part is intersections of aging and the opioid public health epidemic. Next slide, please. And we're going to be looking at the epidemiological data, increased vulnerability and risks for adverse outcomes, as well as specific social issues and the target population. So we'll look at rural population of older adults, and then also grandparents raising grandchildren. And then we'll end with some resources that are relevant to kind of everything we've been talking about today. Next slide, please. So the epidemiology of opioids in older adults, the two main things we see are increasing rates of opioid misuse as well as prevalence of prescription painkillers. So from the NSBUH, the National Survey for Drug Use and Health, the opioid misuse increased for older adults from 2013 to 2014 and decreased for younger adults. We also see a projected double from 2004 to 2020 for increasing rates of opioid misuse among older adults. And then the Medicare beneficiaries are actually the highest and fastest growing rates of this. And then for your prevalence of prescription painkillers, 1 in 3 Medicare Part D beneficiaries received a prescription opiate in 2016, and there has been a significant increase since 2003. Next slide, please. And so now, as we're looking for increased risk and vulnerability, I just wanted to say that a lot of this I've adapted from the American Society on Aging's webinar last November, Aging, Chronic Pain, and Opiate Addiction. Next slide, please. So as we're looking at from a biological lens, the increased risk you see is with comorbidities. So as you grow older, there's more risk for developing different physiological diseases and different comorbidities. And in particular, actually, in Native Americans, this is higher than your white and majority counterparts. So we see a lot more of different, like hypertension, diabetes, back pain, as well as vision loss. And so that's significantly behind your majority counterparts in other ethnicities. Polypharmacy is another issue that is a concern because of the medications to manage a lot of the different conditions. There are a lot of contraindications and things that can interact with each other. And so that's something that increases risk when we're using opioids or when opioids are being prescribed. Other aspects are chronic pain and prescription drugs. And so actually, prescription drugs, the overdose mortality rates related to opioid prescription drugs in Native Americans was a lot higher than other populations in general. I didn't get to intersect Native Americans with aging, but kind of if you can look at the comorbidities with the increased risk of prescription drug deaths among Native Americans, you can see that there is more risk with tribal elders. And then chronic pain, just as there's different things that change in aging and we don't necessarily have built-in physical therapy or exercise things as much as we'd like, pain becomes a bigger issue. And then physiological changes in aging. And so these are just things, changes in metabolism, sedation, respiratory depression, visual impairment, coordination, your attention, and fall risk. And the two images I actually put here are two notable individuals, President Jimmy Carter and Justice Ginsburg, Ruth Bader Ginsburg, very, very well-established, influential, very intelligent, and having significant clout. And you see that even these individuals, aging happens, and the way you feel inside, the way your behavior is, and the way you can think is not necessarily the same as what your body goes through. And so in this picture, we have Justice Ginsburg falling asleep at one of the presidential addresses. And I do this not as, and in the presentation from the ASA, is not as a sense of mockery, but really as a sense of realism. They have a tradition of drinking before the State of the Union addresses, and in this, I think she openly and candidly explained that she had a drink and they usually do it, but because as she's growing older, the metabolizing of the alcohol changed, and so she fell asleep. And so things that we are used to doing in adulthood, they change and they impact the body differently. And the same with Jimmy Carter, he's trying to build habitat for humanity houses and trying to do a lot of these things that are philanthropic and altruistic and active. but the body it's changing. There's increased fall risk, mobility, and so these things that can happen to they do happen to everybody, and so it's not necessarily an impairment of any type of executive functioning or anything to be ashamed of. It really, the body changes, and how we can make sure that that's integrated with how we feel and considerations for how we deliver care around that are really important. And again, so overall, there is just increased risk of mortality. And next slide, please. From a psychosocial perspective, the main issues on a psychological level is at a developmental stage, as you're in late life, death is more common. I always kind of look at how in my age demographic, a lot of people are now getting married and starting families. And so it's just different psychological things to kind of go through. So a lot more deaths that happen in late life, and so increased heightened sense to the edge of mortality. There may be more grief issues as well as depression related to your health, and then different role loss that you may experience because of your changes in your life. Though certainly I would add that, fortunately, within the Native American community, there is, because you have a tribal elder status, there is a little bit more of a role left as opposed to your Western counterparts where there may be more marginalization or isolation of older adults as not really valuable to society. So that is one protective factor we can certainly see with tribal elders. And then from the social standpoint, really looking at loneliness, isolation, and marginalization. So again, in one of the Native Elder Connection studies, they actually found that social support was a little bit better than your white and majority counterparts, but it's still something to kind of be considered when we're looking at older adults. Right now, we are in also a loneliness epidemic, and one of the Surgeon Generals, Vivek Murthy, has explained that actually loneliness is a big risk factor for opiate and substance use, and increasingly so, if you are not engaged and have no sense of purpose or meaning, it can lead to a lot of maladaptive and negative health behaviors. And so other social things we look at are generational patterns, looking at kind of how old that person is and what era they really grew up in. You have the silent and greatest generation from before the boomers, and during that time, addiction was really viewed as a moral issue, and there was so much stigma about it as a moral failing. And so using that to understand how you would treat somebody at that age is really important. The other thing we look at is the boomer generation. This is the first generation that went through the different sex revolution and kind of civil rights and a lot of free drugs, drugs, sex, and rock and roll. And so it's a different type of behavior that you can anticipate or look at as people grow older as well. Next slide, please. So what this means for treatment needs, you'll look at longer detoxification because of the biology of aging. We change physiologically. Detoxification of opioids, but also different substances will take a little bit longer. You'll also, from a physician and treatment standpoint, there'll be a more medical science application. A lot of the geriatricians that I work with talk about there is more medically complex cases because there's increased comorbidities as well as the polypharmacy. So you'll need to be paying careful attention to that. And then other things look at like community health promotion programs with behavioral health and integrated care. Because a lot of these conditions are related to chronic pain or chronic conditions and chronic diseases, a lot of that really relates to lifestyle and how you are taking care of yourself in your community and at home. So a lot of the pioneering work here is done with Katie Lorig, who has pioneered the Stanford's Chronic Disease Self-Management Program. So looking at how we can take charge of our own health, and older people and ourselves as well, take charge of our own health and increase a sense of self-efficacy that we can accomplish more in life rather than just relying solely on a medical provider. And then the last part is looking at age-specific psychosocial interventions and treatment. Some of the things that have been discussed are while intergenerational solutions are important, when you're integrating older adults with younger adults in treatment, oftentimes or sometimes you can see the older adult feeling like a parent. And so they don't necessarily have the space to have their own issues and challenges to work through because they're so worried about trying to mentor a younger person. Now, this is not necessarily the case every single time, but that's one of the things that we have looked at. Next slide, please. And so when we're looking at vulnerable populations with rural and older adults, this is a report from Grantmakers in Aging. There are a couple of different solutions across the nation, actually, and so you can get this report online for free, and the link is also in the presentation. There is Project Lazarus, which is really a community effort integrating a lot of different community solutions, so not just through the healthcare sector, but like your faith-based organizations, community-based organizations, nonprofit organizations. We have Senior Hope Counseling in Albany, New York, and that's kind of speaking to what I said in the last slide about how seniors do want and need their own specific treatment because there are specific psychosocial circumstances that are going to be different. You know, somebody who is youth or somebody who's using drugs and it's impairing their ability to function in school is going to be different than somebody who is retired and working or just retired and living in their community. So a lot of these implications and discussions will be different. Then we have Recovery at 50 Plus, the Hazelden Betty Ford Foundation. That one really targets boomers. So understanding the different sociopolitical trends and the different kind of movements and values that are among the boomer generation, that's taken into consideration for here. And then there is, in Lawton, Ohio, there is a intergenerational solution with the Comanche Nation, I Am Native Drug Free campaign, and that's using culture as prevention. So looking at how traditionally Native Americans have been stigmatized as, drug users, and a lot of these very negative stereotypes, and how the older generation is using that to frame addiction and opioid epidemic as not so much just a biological addiction, but as a social justice problem, that this is not the stereotype we want to keep perpetuating, and so we want to have our youth redefine the narrative, what it means to be Native American, and not to be associated with just different drug use and et cetera. So that's what they've done there, and that you can check out. Next slide, please. And then the positive piece of this, so older adults aren't just vulnerable for opioid use, they are also protective factors. So we've noticed across the nation there are the emergence of grand families. So where parents are either using or dealing with opioid use disorder, the grandparents have been able to step in to support raising the grandchildren. And so there's different work around this, resources, and the new kind of bill that was signed into law last year. Next slide, please. And then these are just the resources and services. The first two are related to aging, and then the last two are related to more addiction and substance use. It's hard, again, to find them all integrated together, and so that's why I just left this up there for you to be able to take a look at. And then that, next slide, please. That brings me to the end of my presentation, and I'll turn it over to Holly Echohawk and Dr. Joan Candell to discuss a little bit more of what this looks like in treatment, as well as with American Indian and Alaska Native communities. Thank you.
Thanks, Ben. Hello, everybody. Again, this is Holly Echohawk. And Ben, I always learn something from you. I really appreciate your presentation. So what I want to do now is I want to share some thoughts that I have from a tribal perspective on some of the aspects of Ben's talk. And then I have 4 follow-up questions, specifically on tribal elders and opioid use for Dr. Candell. So some of my thoughts about Ben's presentation. The first is tribal elder population is different than mainstream and other elder populations in the country for a bunch of different reasons. One is, as Ben said, the lifespan of tribal people is shorter than other populations. The life expectancy numbers it's not really clear. There's not a clear number because it varies by county and rural reservations, urban Indians. But in general, the tribal life expectancy, sadly, is still lower than the white population. For example, in one county in South Dakota, the average life expectancy for tribal people is more than 10 years less than the state as a whole. And that's because of lots of things: access to health education, access to healthcare services, having financial resources for healthcare. If you need something beyond tribal healthcare, transportation issues, all of the things that you all are aware of. But because tribal life expectancy is often shorter than the mainstream population, the eligibility for tribal elder services is also lower. For example, in my tribe, and Pawnee and the other tribes, the Confederated Tribes of Colville in Washington State, the senior population is, if you're 55 years or older, you're considered to be a senior, and you can access, the senior support services that tribes have to offer. So another thing I wanted to talk about from Ben's presentation is the word loneliness. I really picked up on that when he was talking. I believe that the concept of loss and loneliness takes on a much deeper meaning with tribal elders. It's more than just losing your peers as you get older and relatives that you grew up with. I think that tribal elders, and not all, but many that I know personally, have a deeper sense of loneliness because that also includes a sense of cultural loneliness. And what I mean by that is, if you're an older tribal person, the cultures and traditions in the way that you grew up are very different often than the experiences that someone from the current generation is experiencing. So when you lose your friends and your relatives that you grew up with, it's a different depth of loneliness, I think, at times. The other thing that makes that's different about tribal elders compared to just general elders in the country is, I think many tribal elders feel a tremendous responsibility to be a wise elder who should be able to pass on traditions, to be wise, be a wise person, be a cultural and historical resource. But not all tribal people who have reached a certain biological age are able to do that. And there's lots of reasons for that. So just because you are an elder doesn't necessarily mean you're wise. And the reason that you may not be able to fulfill the image of being a wise elder is a lot of reasons that may have nothing to do with. It's usually the circumstances around you. And part of that is another reason that tribal elders are very different than mainstream populations is that they share something unique that some would describe as either a shared experience or shared group trauma, and that is the tribal boarding schools. If you are an tribal elder, very often you have gone through and attended tribal Indian boarding schools across the country. Not so much anymore, but in certain generations, definitely. And we know that exposure to traumatic and often violent events, whether that's at home or in school, can be a lifelong weight on any person. And as human beings, we try to find a way to cope. When we've experienced trauma or witnessed, it doesn't have to necessarily happen to us personally, but even just witnessing trauma, we try to find a way to cope with that. Sometimes that's successful, sometimes that's not. But we also know that unresolved trauma affects physical health as you get older, affects emotional health, your ability to make healthy decisions, and a host of other behaviors. So as we get older, as tribal people, and as anyone that gets older, you have legitimate physical limitations sometimes, and pain management is available. Prescription pain drugs. But sometimes that can introduce tribal elders to the opiate world without them being, they don't necessarily use the word opiate. I think they often think of it as pain medicine. But but that can ease their pain and increase their mobility, but it also can contribute to vulnerability. and sometimes dependency on prescription pain medicine. For example, in one good visual of this that I came across is in Bethel, Alaska. They were having group support for the World Elder Abuse Awareness Day, and there's this photograph of all of the Alaska Native people who, the way that they're going to show their support for that against elder abuse is they made signs and they went out on the street in front of the hospital, if you've been to Bethel or if you're from Bethel, and during the lunch hour, during the busiest time when cars are coming and going, and they held up all these different signs, and this one Alaska Native elder person had a sign that says, "Do not take their money or meds." So there is a factor of vulnerability as well, both in terms of becoming dependent on pain medication as well as risk of being robbed. So, but in general, the reality is that the opiates are in Indian country. They're here. Tribal people have consistently had the highest drug overdose deaths every year from 2008 to 2015, and the National Indian Health Board showed the highest percentage by tribal people of drug overdose deaths, an increase of 519%. So the opiate epidemic is in our tribal communities, sometimes more so than others, but it's here. So I just have a couple of thoughts about treatment considerations, and I have the questions for Dr. Kendall. So Ben talked about considerations to think about in terms of treatment that for people who are elderly, you have to think of it from a biological and aging perspective. Many tribal health experts believe that to address the root cause of drug use in our communities, that you have to recognize that historical, and not just historical trauma, but current ongoing day-to-day trauma is often underneath the start of drug misuse. It can range from self-medicating as a way of avoiding pain, all the way to learned dependence through legitimate prescription pain medication. So tribal people can become dependent on opioid pain medication or alcohol or other drugs and become dependent because they're looking for short-term relief from long-term pain. And that long-term pain can be physical or emotional pain. So the last couple of things about my thoughts about treatment for tribal populations is all tribal people have strengths. Sometimes those strengths are sitting in idle. They're like sitting in neutral. And good treatment recognizes that those strengths are there and they need to unearth those strengths and move them out of neutral into going forward here. And it's usually trauma history that has interrupted what most people's usual their reliance is on their strengths, but trauma history is frequently the source of that interruption. The other thing is to recognize, of course, that current ongoing trauma, day-to-day traumas, car wrecks, injuries, loss of relatives, is as real as past historical trauma. And then my last two little notes is religious beliefs in some tribal communities and held by tribal elders may be as strong and sometimes might outweigh or be more influential than cultural beliefs. And then my last thought is a tribal elder that has a trusting relationship with a primary care doctor, and many of them do, that may be the gateway to their accepting other kinds of helping support. So those are my general thoughts, and I have some questions for Dr. Kendall. And the first question is, what are some legitimate reasons for opioid use by tribal elders?
Well, thanks, Holly. I appreciate hearing your thoughts earlier about the issue as well. So let me first just briefly describe what opioids are, in case people don't know. Opioids are a class of medications whose main purpose really is the control of pain. That's what they work best for. It includes illegal drugs like heroin is an opioid, but also includes prescribed medications like hydrocodone, oxycodone, morphine, fentanyl, that class of medications. And these medications work really well for acute pain. That's the main thing that they help with, and they're unrivaled in that. They work great for acute pain. And we used to think that they worked great for chronic pain as well. But we've learned a lot over the past decade or so that they may not be quite as good for chronic pain. When they're taken for long periods of time, not only is the risk of becoming addicted increased, but they also don't work quite as well to control the pain if taken for long periods of time. And they can sometimes make people feel worse pain, which is known as opioid-induced hyperalgesia, where things become actually more painful. And when I have patients that are taking opioids for chronic pain, because some people do benefit from taking opioids for chronic pain, and as long as they're getting benefit from them and they're using them as directed and they're not misusing their meds, I really need to follow them closely and see them frequently, because I still worry about the effect that these strong medications have on them and how they might interact with other medications they're taking, because they could be on lots of different medications. And I also have concerns about them, the safety of these medications in their homes, and how they might interact with other medications, and the safety in their homes. And maybe people, as you mentioned, Holly, people may be interested in stealing them or taking advantage of them. So I talk to patients about keeping them in a locked cabinet or a lockbox. And one safety measure is I also usually co-prescribe naloxone to them in case of overdose. And another safety measure that we all do is when we prescribe these controlled substances is to check what's known as the prescription monitoring program, which is an online database that's operated by states. Most states have them. And it gives us the ability to see if patients are filling prescriptions that they've gotten from other clinics or other doctors or other pharmacies. Because the last thing we want to do is inadvertently prescribe more of these strong medications to them if they're getting them from somewhere else.
Thank you. So what about, Dr. Kendall, what are some alternatives for pain management, low-cost or no-cost alternatives for pain management that tribal elders can use instead of taking a pill?
Yeah, so that's a really good question, because, pain management doesn't always come down to taking opioids or even taking pills. So there are other types of medications that we can prescribe for people that aren't opioids, so different pills that they can take. And then there are also topical things that aren't pills at all, that gels and creams that people can rub onto painful spots, and those can be very helpful. But really important to mention that there are also a bunch of non-pharmaceutical options that have been proven to really be helpful, like physical therapy and acupuncture can be tremendously helpful. Really any form of movement therapy, just getting up and moving, can be super helpful for controlling pain. And those can be traditional ways like powwows, dancing, or Eastern like yoga, Tai Chi, or Western, just simply walking, getting out and going for a walk, going to a fitness center, really anything that gets people up and moving. And then creative outlets can be very helpful for helping people controlling pain. music, including drumming, art, anything that's creative. And then there are massage or other manual therapies can be very helpful. And we've also found that strong social and cultural support can make a huge difference for people with any medical condition, including chronic pain. And I know that for many of my patients, especially the elders, they prefer to not take pills every day. And that's for their pain as well as their other medical conditions. Most people don't want to be taking a whole bunch of medication. And, it's tricky because we really don't want our elders to be in a lot of pain. And one of the things that happens as we get older is we often do get pain. But it can be really limiting in terms of their function and their independence, and we don't want to limit an elder's independence. So it can be a real balancing act. We need to keep patients safe, but we also want to treat their pain. So it's not always an easy thing to do. And I just want to mention that some people do try lots of different modalities, and they find that not much else works for them, but they do find that low doses of opioids taken over a long term can be very helpful. And as long as they are benefiting from it and they don't have evidence of abuse, and it can improve their function and quality of life, they really shouldn't be stigmatized or discriminated against because they're on opioids. So opioids shouldn't be used as first line for chronic pain, but it can sometimes be very helpful for people if they found that other things are ineffective. So the bottom line is that it's really patient-specific, and it needs to be individualized for each person.
Thank you. And you actually answered the third question, which is some of the risk factors. So I'm going to skip to the fourth question in recognition of the time, which is, how can people tell if someone in their family is addicted to opiates, even if it's an elder? And what can they do if they suspect it?
Yeah, so that's a really important question that we all need to be thinking about. And sometimes, really, it's hard to know if someone that you love is actually addicted, or if they're just taking these opioids. Sometimes people don't know, are they addicted or not? If someone has been taking opioids for a long time, they may be physically dependent on the medication, meaning that if they were to stop taking it, they would feel withdrawal symptoms. But if they're taking their meds as directed and they're helping them, they aren't necessarily addicted just because they have withdrawal symptoms. So one easy way to kind of get the concept of what addiction is to kind of look for the behaviors that are consistent with addiction. And so I like to think of it as the 4 C's, and I'll try to be quick here in the interest of time. But the 4 C's of addiction, the first C is compulsion. So if that person has the desire to use, they're thinking about it most of the time, they're sort of obsessed about it, they can't stop thinking about it, they're just sort of driven to using, that's compulsion. The second C is craving. If they have strong urges to use and they're just constantly wanting to use and use more. The third C is control. So a lack of control, really. They're unable to stop using even though they know they should. And then the fourth C is consequences. So continued use despite negative consequences, be they financial or social or health. People see that there are consequences of their use, but despite that, they continue to use. So those are the 4 C's of addiction. And if people were to see that in their loved one, whether they're youngsters or older people, they can talk to them and try to see if they can get in to see a counselor or their primary care physician, see if they're willing to get help with that and see if it truly is a problem of addiction. The other really important thing to share with someone is that there are well-studied, evidence-based treatments for opioid use disorder if they are addicted to opioids. And these should be offered to patients no matter their age, even if they're older. And there are, I'll mention that there are 3 FDA-approved medications to treat opioid use disorder, and Ben mentioned these as well. They're buprenorphine, methadone, and extended-release naltrexone. And medications plus supportive behavioral therapies are known as medication-assisted treatment, and that really is the gold standard for treatment and should be offered to anyone who has problems with addiction.
That's great. Thank you very much, Dr. Candell.
Mm-hmm.
So I'm going to, that concludes our section of the presentation, so I'm going to just pass this back to Julie Cahoon.
All right. Thank you so much for your discussion. That was full of so much useful information. Certainly appreciate that. So we have actually run up to the top of the hour. So if for the next few minutes, if folks have questions, please put your questions in the Q&A box. And those have all been recorded. And what we'll do is we will compile all of your questions and then work with the presenters to provide responses to those, and then send an email back out to those that have attended today so that you have access to the answers to your questions. So with that being said, I'd like to thank our presenters for joining us today and sharing information about aging and opioid use disorder treatment considerations for American Indians and Alaska Natives. In closing, I'd like to remind everyone that today's webinar was recorded and that the audio and presentation slides will be made available online at cms.gov on the Tribal LTSS Technical Assistance Center website. Thank you again for joining today's webinar. Our session is now concluded.